Welcome to the Pharmacy Quality Solutions Quality Corner Show, where we talk quality of healthcare and explore what that actually means. Let's dig into performance measurements, the equipped platform, pharmacy goals, and personal goals. We will also occasionally cover topical healthcare news and maybe throw into the conversation a few of our own nerdy passions and hobbies. So turn us up. The Quality Corner Show starts now.
Hello, Quality Corner Show listeners. This is your host, Nick Dorich, and we welcome you to episode 47 of the Quality Corner Show. Last week's episode served as a launch for American Pharmacist Month, a month dedicated to supporting and celebrating that you know your pharmacist and that you know your medication. While yours truly thinks this should be a year-round celebration, I can also accept that one particular month for this celebration is satisfactory. During that last episode, Michael Hogue joined us to talk about the meaning of the month-long celebration and to share some of the current challenges and opportunities for pharmacists. We ended that conversation on a positive note about pharmacy, and for today, we're going to continue down that lane. To help us cover the topic, we're going to bring in another pharmacist, someone that has also served as an advocate for expanding pharmacy services and services that pharmacists can be paid for. If this sounds like a great idea to you, you're not alone. So today's guest is Julie Akers from the Washington State University College of Pharmacy and Pharmaceutical Sciences. Julie, welcome to the Quality Corner Show.
Thank you for the invitation, Nick. Happy to be here.
Julie, before we get into the heart of today's discussion, our audience needs to know about our guest and who you are. Do you mind giving us a little information about your background and tell us about some of the great things that you've done in the pharmacy profession?
Sure. Well, I graduated from Washington State University in 2000, worked for Bartell Drugs in Seattle from then until 2011 as a pharmacist, pharmacy manager, and then as a district manager. I then left and went to a physician-owned clinic, and I ran their outpatient pharmacies, ended up recommending that we sell the pharmacies, and then I was a broker for a year. Then I moved to Eastern Washington and started teaching at the same program that I graduated from. So I've been really active in my state association. I've been on the board of directors for over a decade now as a director at large, on the executive committee, served as our association's president in 2012. And then now I'm appointed as our college's board designee. Also had the privilege of serving at the federal level as well. So I'm currently on the Government Affairs Committee for APHA. And then with my teaching position, I am involved in a course that's really aimed at clinical decision-making in the community pharmacy setting for students, but also teach an advocacy elective course.
Thank you for that background, Julie. A message to our listeners before we continue with the conversation. Julie is not the first guest from the Washington State Pharmacist Association that we've had. You'll recall that back in episode 22, we had Jenny Arnold to talk to us about the emergence of COVID. So my point here is quite simple. The folks in Washington State are doing some great things for pharmacy, and if you're not paying attention to them, you definitely should. We can always learn from those that are leading the pack and from those that are pushing the practice of pharmacy. That's why we've brought in Julie today. We want to talk about the tactics that can help expand pharmacy practice and services. Julie, now that I've provided additional background for our audience, are you ready to inform and educate?
Let's get started, Nick.
Excellent. To start our questions for today, let's get into some of the important context. What's been unique about expanding pharmacy practice in Washington? Does this tie into pharmacy, quote unquote, provider status? And what has Washington accomplished already? And what does that mean for the road ahead?
So, Nick, what's really unique is our Practice Act. It's been in place since 1979, and truly it was designed to allow for innovation, including pharmacists as care providers with delegated prescriptive authority. So one important element in our Practice Act is there's no list. There's no list of disease states or certain medications where it's really limiting the pharmacist to only those specific things. It's very broad and open. So the other unique thing about our law is there's been a companion bill. So a law passed in 1995 that we call the every category of provider law. So in 1995, really it was the chiropractors that were frustrated that physicians and ARNPs and others were being paid for services and their claims were being denied. So they got a law through in 1995 that said you can't categorically deny a provider if you would pay somebody else for that same service. What was great for us in pharmacy is that 95 law didn't list chiropractors or any other providers. So we saw that as applying to us as well. So what did we do after that law got passed in 95? We flooded health plans with applications to be providers. And unfortunately, not everything was, great after that. We got a lot of denials saying that they were paying pharmacies for medications, and that was, in their belief, how they were complying with that law. We didn't back down. We didn't agree. We fought for 20 years. It wasn't until 2015 that we got a law passed that we jokingly call the do what you were told to do in 95 law, that specifically stated that private health plans were required to have pharmacists included in their networks. Now, this really gave us provider status in our state. It had some delayed implementation. So it started in 2016 for our health systems, and then in 2017 for our community pharmacies. It's great. It's amazing to have that provider status level, but we also recognize that it was specifically just for our private plans. We still have some work to do from a public standpoint, as well as at the federal level for Medicare.
Thanks, Julie. Great place for us to get started. You already noted a little bit that while there is provider status in the state, there's also an impact on the federal level. So while Washington in your state with private groups or with employers or private health plans, it's there. You can activate it. But there's still an opportunity where your group is being active at the federal level, working with associations. You talked about the timeline and something of a 20-year process. So for myself, as someone that's been talking about provider status and advocating it for roughly 13 years, sounds like I still have some work to do. In general, one item towards the end of your points that you referenced, going into effect in 2016 for health systems versus 2017 for community pharmacy. What was the background or rationale for why implemented in 1 year for health system versus the following year for a community pharmacy practice?
Well, I can tell you that the original push that we had to fight against was for all of it to be implemented in 2017. And the reasoning was a lot of those private plans who had fought against this legislation said that it was just going to be a huge hurdle and take a lot of work for them on their end to get it set up where they can accept pharmacists as providers. We pointed out to them that the credentialing and privileging process was already in place for other providers and health systems, and that those settings were doing their own centralized credentialing and privileging. And all they needed to do was add pharmacists to that list with what services they would be privileged for and submit it. So their argument that it would take all of this extra work on their end, we really were able to fight that, at least from the health system side. And so we did get it to where it would be implemented in 2016 for those settings, knowing that it was going to take a little bit more work, especially on that private health plan side, to get set up on their end to accept community pharmacists into their networks.
Great. So if I can think about it a different way, Julie, this was thought of to be a little bit of a chicken or the egg situation, but luckily that egg had already been laid and was just ready to hatch here because the systems were already in place with the health system. So that actually makes a lot of sense. And I think there's an important lesson there for pharmacy. Just because you're not able to do something here and now doesn't mean that you can't be building for it, right? We need to have an implementation plan. Your pharmacy teams need to be ready for when that action does come, that you can jump in right away. We'll move to question 2, Julie. And for this, I want to explore what have been the biggest challenges with expanding scope of practice or pharmacy services. As I understand it, it's not as simple as a legislative body signing a law or a state regulatory body updating practice. While there is a legal component about what you can do, I also assume there's a conversation that needs to happen with the payers, with the employers, of course, the patients around what they can expect from a pharmacist. So if you don't mind, what has this process been like and what are these conversations like?
Well, I can tell you there's definitely been some challenges, some larger than others. First, I would say is that credentialing and privileging process. So the health systems, like I said, were much more ready to go January of 2016. But I can tell you, it wasn't like ripping a Band-Aid in January of 2017. There wasn't a floodgate of community pharmacist provided services being submitted to those private health plans. there was a lot of work that needed to go into those systems. So this was completely new for community pharmacists. We were set up to bill PBMs through a switch company. We weren't designed, or at least our systems weren't designed to have robust electronic health records with all of the things that you need for CMS billing standards. Our pharmacists didn't really have a strong understanding of ICD-10 codes and procedure codes, or time-based versus complexity-based billing. There was just so much education that needed to happen, and not only on the credentialing and privileging process, which is quite cumbersome if you don't have a department that's managing that for you, like most health systems do. But there's also some of those technology hurdles. Again, our systems aren't set up to bill medical insurance, or at least they weren't. Some of the new EHRs that were coming out didn't integrate, and still many of them don't integrate with our pharmacy computer systems. And so that's a challenge. But also that education, both education on billing procedures and doing that accurately, but also some of the education that's needed on the disease states. Some of our pharmacists, I'll put myself into the same bucket. We were trained in a system where you knew a lot about the disease states, but then your training was how to write a strong SOAP note or make a recommendation to some other provider. And we really weren't given the tools, or, all honesty, the confidence to be that provider. So I was really excited to see our state association developed a very robust medical billing training, but they also developed quite a bit of CE programs for some of the more common conditions that pharmacists are providing out in those communities, just to give them that education. Then we had to go to the health plans. They really had no clue what pharmacists could do. Many of them were shocked when we started talking about prescriptive authority, whether it be independent or delegated in your state. They had no idea that pharmacists were already doing many of these things in their pharmacies, but having patients pay out of pocket. We had meetings with our state Medicaid. Knowing that our legal mandate was private insurances, we were hopeful that Medicaid would voluntarily join in. And I can tell you those conversations were positive, especially when we brought up the many pharmacies in our state who were seeing patients for uncomplicated urinary tract infections. Their eyes lit up. They had no clue that community pharmacists were already doing this. And they shared with us that in Central and Eastern Washington, it was their number one wasted healthcare dollars from people going to ERs for uncomplicated UTIs. So they were excited to think about pharmacies and communities being able to help them with some of that. And then, of course, there's the patient. That old adage, if you build it, they will come. We didn't really know if we started providing these services, these companies and pharmacists going through training and the supplies needed and the resources needed, both physical and financial, to start some of these services. Are you really going to have patients that are either aware or willing to have the pharmacist be their care provider for these things? Through all these pharmacies that are doing it already, that are having people pay out of pocket, similar to an office visit if they went to their doctor's office, we really have seen it be something that people were willing to do. And many of these companies started with a few locations, and they're now expanding it across the state. But it's not perfect, right? We need to switch to medical billing. That will really expand, I think, the number of people who will access those services. And we need to get over some of those barriers, being technology and just billing and credentialing and privileging, so that our pharmacies are set up to do this. It's exciting to see how far we've come, but Nick, we've got some work to do still.
Thanks, Julie. You covered a lot of different areas, and I'll look to summarize the points here, because if I'm thinking about the highlights, we need to communicate with legislators, regulatory bodies, so that we can, have the authority to do this, provide other services. We need to advocate with technology companies so that we can have the capacity to document a bill. We need to advocate with the payers so that we can get paid and recognized. We need to communicate with the providers so they know what to expect in working with the pharmacist. We need to communicate and advocate with the patients so they know what to expect working with the pharmacist. And we need to communicate and advocate with our staff. I'm not the complete math expert, but I listed more items there than I can count on one hand. So when we're talking about provider status, it's not just that we sign on to a letter to our federal legislators or at a local level. There's a lot of local activities or maybe even activities in our day job where we need to work with those that are part of the management, those that we work with as an organization with the patients. And Julie, I think from that standpoint, signing on for a letter with a federal provider status support, that's always something that can be very easy, takes a couple clicks for most pharmacists to do with their advocacy or associations that they may be a member of. But from your point of view, what are other easy ways or simple ways for somebody who's new to this, who's just jumping into the process? What's the best way to get involved and to help get this train rolling?
So I think it's just having a strong understanding of all those pieces, and it is really complex. You don't have to be the expert for all of it, but get involved. And if you understand your piece of it, if you find your passion, I think that it's going to be much easier to get involved and feel that you're really accomplishing something. So if you're somebody that's legislatively focused, go for it. Get on to any of the national organizations or your state organization. I know they're all working towards provider status or improving the language that they have in their own state if needed. But then also look at the technology, be involved, try to get more education, make sure that you know what conditions are really being provided by pharmacists. And when that switch happens, either in your state or federally, are you ready? Are you ready to provide that level of care? Do you understand medical billing and coding? Make sure that you are prepared, because the last thing we want to do is get provider status, have people start providing care for people, and we're not doing it exceptionally well. And I don't think pharmacists would do that. We're a little risk averse. So I think a lot of people are going to want to reach out and learn as much as they can. And the more of that you can do before that provider status switch is flipped, the better. But don't be frustrated if it comes after. That's what we're seeing in our state. We're 3 years now post it being implemented in community pharmacies, and we don't have a lot of community pharmacies billing medical insurance yet. That can seem really frustrating. It can seem frustrating to the legislators who fought for you to have this, and making sure you're going back and educating them on what these challenges are, and really just not giving up. I mean, remember, it took us 20 years of really banging our heads against a wall from 1995 and that every category of provider law to our 2015 legislation. So I would say don't get discouraged and just keep fighting.
This can really be summarized, Julie, as prior planning prevents poor performance. So once we've got something in there as an opportunity, we need to make the most, we need to take the most action that we can to be successful. As a profession, we often talk about the extent of our training and education for pharmacists, how we're uniquely positioned as the medication experts. But the reality we've already referenced is that the expanding role and services do require training. I did get education and training as a pharmacist when I graduated from the University of Rhode Island about different disease states and screening, but I'm not practicing in a direct patient care role now, obviously. But even if I were, it's been years since I've had some of that training, right? So it's natural that we're going to need to have a refresher or get more information so that we are up to date. A lot of that can be done with CE and training courses, but when we're taking additional steps, we need to be thinking very diligently, and we need to be vigilant that we're making sure we have the right information, because ultimately that allows us to be most successful with the services that we're providing. Julie, our third question here for you: within pharmacy, what do we need to do so that we're ready to face these new opportunities head on? We've already talked a little bit about the education piece, but would like to have you dig into that topic a little bit more.
Sure. So you really hit it, Nick. We have our students and our future pharmacists, but we also have those that are out in practice. So from an academic standpoint, we need our pharmacy programs to go beyond the accreditation standards. Of course, we have to meet accreditation standards, but there's so much more that we can put into our curriculum. And, in some schools they're doing it, but it's electives. So we need to make it required curriculum that really includes strong clinical decision-making. Like I said, not just SOAP notes and making recommendations to other providers, which is important, but we need to include those scenarios where that pharmacist is the person making that final decision. They're making the assessment. They're deciding if a prescription is needed or not, and they're the one actually writing the prescription as the provider. They're doing the follow-ups. But also in our programs, we need to start adding in medical billing and documentation. If we're going to expect pharmacists to be doing this in practice, we need to go beyond teaching traditional pharmacy billing and going through PBMs that we do in our programs. And we need to mirror our colleagues in medicine and nursing and others that have more robust medical billing training. But then that flip side, as you mentioned, are practicing pharmacists. So we need to have conferences, we need to have CE programs. And as I mentioned, our state association has some of that online. But I can tell you with some of the studies I've been involved in where I had pharmacists go through that training before they started offering these services, they weren't confident after just doing the CE. So we had live training days where we went through patient scenarios of, do you refer this patient or do you prescribe, or really helping them with that, applying the clinical decision making. And that's where we saw that confidence level increase. So we need to have more of those, whether it's through a virtual world while we're dealing with COVID, or in person as we get back to conferences. We need to have those education pieces, but we also need that live practice where people really feel confident.
Julie, I really appreciate that answer once again. The minimum competency part to me is really important, right? And that's exactly what it is. If it's a school of pharmacy and they're just meeting the standards, that's the minimum expectation. Same thing like when I passed the NAPLEX. That meant I was minimally competent to be a practicing pharmacist. But there's a difference between what that minimum competency or expectation is versus advanced form of the practice. And especially if we're expanding what pharmacists can do, there's going to be new opportunities that are there. I think your perspective on this and why I was glad to have you on the show, you're working in the academia space now, but you've had firsthand experience working with a pharmacy group and working with different pharmacists that not all pharmacists are going to be the same, right? You're going to have different levels of experience there. And even to that point, you're going to have to identify the pharmacist or the student pharmacist that want to be the ones pushing that forward and really making a change for the profession. We need some people to be the leaders and to be the advocates. We need some people that are the ones that are going to be working on these advanced practices. Also, I would add, you talked about the importance of data and having that sales pitch to health plans and to other payers. We need to show the evidence. So we also need those in pharmacy that are researchers that can really help us interpret this data and show that there is a strong value, that there is a strong ROI. So before we move to our final parts, Julie, any other summary comments that you would add?
I just want to add to the point you just made is, for some of these companies to put time and energy and their resources into these, it's a little scary when you don't know what that return is going to be. And I would encourage people to reach out to their local academic centers. That's really, I think, how we got so far in Washington State, especially with some of the pharmacies that are offering minor illness and condition services. There's a lot of training and expense to the CE and supplies, and we were able to get grants to help with some of that. But in addition to that, we helped them implement that training. We designed that live day for them to feel more confident and comfortable. And we are collecting data and going to be disseminating that so that others can see that it worked, and comparing that service to other practice settings to really see what impact did it have on our healthcare dollars.
Julia, a quick side note for your final comments. One of the most disheartening things that I hear from a pharmacist or a frontline pharmacist working in the community is the quote unquote, I'm just a community pharmacist. There's so much more that pharmacy can do. So if you want to be doing more, it's how you push messaging, how you look for opportunities within your organization. But as you referenced, there's schools, colleges, there's research centers that are in a variety of different settings, different locations that are out there. So if you've got an opportunity to do more and help show what pharmacists can do for other programs, contact these, whether it's state association, pharmacy schools, research groups, identify what are they working on? Is there an opportunity for you to be involved with a program or a project? Maybe it's you being hands-on with the patient care, but maybe it's other ways that you can be involved for research ideas. Reach out. Let's be innovative. Julie, you referenced it. Pharmacists by nature, we tend to be risk averse, but we can't let that control us. So regardless of what your practice setting is, be adventurous, find a way to get involved. Now, with this, Julie, I'm highly confident we could continue this conversation much longer than the 15 or 20 minutes we've already been on. And I've been adding a lot of notes to my parking lot list of ideas so that we can have you back on the show for a future recording. But I am going to try to take us in for a landing instead of continuing to circle the skies. At the end of last week's podcast, Michael Hogue spoke about the importance of being involved with pharmacy. It's not just a job. It's not just our profession. It's a commitment to patient care and excellence in patient care. If you don't mind, Julie, what would you recommend to our listeners so they stay involved and that they stay active so that they're making the most of this American Pharmacist Month?
So I think the most important thing is to find what you're passionate about and join organizations, but join the ones that are right for you. Whether that be APHA, ASHP, NCPA, whichever one really calls to you, join, but don't just join, you need to be active. And I know a lot of us have time constraints, I do as well, but if you find the things that you're truly passionate about, then it doesn't really seem like work. Maybe it's not going to be the same passions I have. You might not be interested in government affairs or legislative advocacy, but potentially there's a special interest group or some way that you can contribute and help us fight this fight. Maybe you're one of those people that's more than willing to go testify at the national or state level, and maybe you're not. That's okay. But reach out, as Nick said, reach out to your state associations, reach out to different organizations in your area. Also at the national level, share your experiences, share your struggles, share your wins, and let them take that story to help push at the legislative and regulatory level. So the key really is to find your passion and just be involved as much as you can.
Last night, Julie, I was watching a Canadian comedy show. I won't mention the specific name, but the theme of this episode was do what you love and you'll never work a day in your life. That exists for associations and professional work. And sure enough, there's times in our life where that opportunity to participate may wax or may wane, but being active and to the extent that you can and finding your passion is going to be the key to success for each and every one of us. Julie, with that, I do want to bring us to the final conclusion, and I'm sure our listeners are going to have additional questions for you as an expert in this field and as someone who's had a lot of great experience in the state of Washington. So if someone does have a question and they'd like to hear from you, how can they contact you?
I'm happy to receive emails from people. That's probably the easiest way, especially in COVID times. My phone number in my office is not going to have anybody answering it. So my email is julie.akers@wsu.edu. So julie.akers@wsu.edu. And happy to take questions, comments, or if you want to find new fun ways to collaborate, I'm open to that too.
Thank you very much, Julie. I certainly appreciate you joining for the Quality Corner show today. As you said, it's important that we share and communicate about success. And that's why I went to you. That's why I went to the great folks in Washington, because you've had a lot of success that many other states look at. But what I think we've also learned from you is that the work isn't done. So while many states are celebrating Washington and its efforts, the folks in Washington are still hitting the ground, still running to get more opportunities up and running for pharmacy, and more importantly, to benefit patients. And that's what we're here for. So with that, we're going to go ahead and finish today's episode. I think we're going to finish with the message that we've all been able to get behind. So with that, I appreciate everyone listening to this episode of the Quality Corner Show, and our one final message from the PQS team. Our team here at PQS has a couple of favors to ask of you, our podcast listener. First, we encourage you to share this podcast with 2 friends, because if you share this with 2 friends and each of them shares it with 2 friends, it really helps us hit a larger listening audience. Second, we also want to take a moment to remind you to subscribe to the podcast wherever you may find it. And then, if you have any questions or topics you would like us to address, please contact us. The best way to do so is to email info@pharmacyquality.com. Let us know what is on your mind and what we can address so that you are fully informed. Our goal is to continuously improve our podcast content and to provide meaningful information to our listeners based on current topics in healthcare, technology, and quality measurement. We want to help you become as effective as possible in how you care for patients and improve public health outcomes. So until next time, we wish you well.